What is it about the human race that makes us so resilient? Do we owe it to our advanced biology, our ability to rally and endure during crisis, or our collective knowledge about our environment and ourselves? We cannot really attribute resilience to a single cause, but we can appreciate that there have been as many experts as there have been challenges. Across history and even more recently, public health crises have forced us to innovate, not just in medicine, but in how we detect, understand, and control diseases. Take the plague, for example. In the 14th century, the Black Death swept through Europe, killing an estimated one-third of the population. At the time, no one knew about bacteria or vectors such as fleas on rats. Yet through observation and necessity, city-states like Venice pioneered quarantine, requiring ships and travelers to remain isolated before entering port. This was one of the earliest large-scale public health interventions, and it worked well enough to become a cornerstone of infectious disease control for centuries. Fast forward to the 19th century, and the world faced repeated cholera epidemics. In London's 1854 outbreak, physician John Snow applied what we now call field epidemiology. By mapping cases and tracing them to a single contaminated water pump on Broad Street, he demonstrated that cholera was waterborne and not caused by bad air. His work, combined with sanitary reforms championed by Edwin Chadwick and others, led to massive investments in urban sanitation systems including sewers, clean water supply, and waste removal that dramatically reduced waterborne disease. Each of these milestones reflects a core truth of epidemiology. The right intervention depends on understanding the cause, mode of transmission, and the population at risk. Epidemiologists are leveraging the latest in biostatistics, geospatial mapping, and predictive analytics to track the spread of infectious diseases in real time, detect anomalies that may signal an outbreak, and model the potential impacts of interventions before they are deployed. Whether it's genomic sequencing to trace a pathogen's evolution, machine learning to forecast seasonal flu peaks, or dashboards that inform policymakers within hours, the discipline is evolving at a pace unimaginable to the pioneers of quarantine, sanitation, vaccination, and antibiotics. In all of this, one thing remains clear: data is the lifeblood of public health action. But having data or access to it is one thing. The difference between reliable answers and misleading information is always a few careful checks and hours at the keyboard. Before data can be analyzed, it needs to be cleaned. This is a non-negotiable early investment that determines whether analysis yields truthful, actionable, and reproducible results. Data cleaning utilizes a systematic approach of steps that at their core have a documented workflow that moves from inspection to validation and finalization. Data cleaning begins with spending some time planning and documenting. This includes naming the analytical questions, listing the variables you need, and specifying acceptable ranges, formats, and what counts as missing. Define pre-processing procedures including filtering, type conversion, recoding, deduplication, and any masking done for privacy. Clear rules up front keep the rest of the process honest and reproducible. Start by looking at the raw data with curiosity. Inspect variable names and types. Scan a few rows and profile distributions using frequencies for categories and summary statistics for continuous measures. Use those first looks to flag impossible values, duplicates, or surprising cardinalities. That initial inspection is your earliest opportunity to catch problems before they propagate into derived variables and models. Next, make everything consistent. Standardize dates, numbers, and categorical labels so they behave predictively in joins and analyses. Normalize units and harmonize category codes. Clean and canonize unique identifiers so merges downstream don't create silent mismatches. Consistency at this stage saves hours of head scratching later. Treat missing data as information, not an annoyance. Assess whether missingness looks systematic or random. That assessment determines whether you impute, weight, or keep explicit missing codes. Document the rationale of whatever approach you choose so future users understand the trade-off and assumptions behind your decisions. Look for outliers and outright errors with domain knowledge as your compass. Cross-check suspicious ages, heights, weights, or clinical measures against plausible ranges and study definitions. Correct clear entry mistakes, flag implausible records, and decide whether extreme but plausible values should be transformed, modeled explicitly, or retained for sensitivity checks. Validate relationships and integrity across fields. Enforce logical rules, such as start dates preceding end dates, age matching birth dates, and totals reconciling with subtotals. Referential integrity checks and cross-field rules catch the kinds of errors that single, simple variable checks miss. Finish by documenting and packaging the clean dataset. Produce a data dictionary that defines each variable, its units, allowed values, and derivation logic. Commit cleaning scripts to version controls with clear messages and preserve the original raw files untouched. A well-documented version dataset is the handoff that turns one analyst's hard-won trust into a resource the entire team can rely on. Cleaning is not just fixing mistakes. It's translating messy human reality into reproducible, analyzable truths. When data cleaning is treated as a deliberate, documented practice, every subsequent analysis becomes faster, clearer, and more defensible. Epidemiological answers depend on assumptions we can trust. Clean, well-managed data lets us estimate rates, identify risk factors, and evaluate interventions without hidden bias. Poor data can delay responses, misallocate resources, and erode your team and public trust. On this channel, we showcase how both time-honored and cutting-edge biostatistical methods are applied in real-world epidemiology and public health. Through clear demonstrations of generalized linear models, survival and longitudinal analysis, factor analysis, structural question modeling, and selected machine learning approaches, we illustrate how rigorous quantitative tools identify risks, measure impact, and evaluate intervention. Our aim is to bridge theory and practice. We translate methodological insights into reproducible workflows, critically assess assumptions, and highlight pragmatic choices that matter in applied settings. We intend to demonstrate how these techniques are being used by epidemiologists and other public health experts to address existing problems, develop and assess interventions, and as a means for transforming research ideas from thought to practice. We will demonstrate these techniques primarily using Stata while emphasizing that rigorous analysis is not bound to a single tool. We will showcase how other platforms such as Python and Excel can be integrated into the analysis workflow in order to maximize data accessibility and utilize custom transformation, analysis, and visualization libraries. We will also demonstrate reproducible workflows and code that can be adapted in your own work. So, whether you're a seasoned analyst or a newcomer with a research question, you will find thoughtful examples, transparent code, and discussions focused on turning ideas into effective, evidence-based action, or perhaps an idea or methodological approach to incorporate into your own analytics project. Engage with us in the comments, give us a like, and if you like what you see, remember to share and subscribe. My name is Andrew, and this is Monkey with a Keyboard.